Class, this will be your discussion on glaucoma. Now, when I talk about problems in glaucoma class, you need to remember that glaucoma is talking about your intraocular pressure. So again, the main problem in glaucoma is the increase in your intraocular pressure. Recall that the normal intraocular pressure should be less than 21 millimeter mercury. However, in your patient with glaucoma, the intraocular pressure is high. And what happens if the intraocular pressure is high? It would compress the structures in your eye, and particularly, it would also compress your optic nerve. So recall that your optic nerve is cranial nerve number 2. And as cranial nerve number 2, its function is purely sensory. Because of that, there will be atrophy and there will be visual field loss. As I had mentioned earlier, your glaucoma is among the emergencies in ophthalmology, okay, which means that it needs to be addressed, especially if I'm talking about acute or narrow angle glaucoma. Okay, we'll discuss later on the two types of your glaucoma. Now, let's focus first on these types. These are the types of glaucoma: primary, congenital, and secondary. These are the types of glaucoma according to their etiology. So when I talk about primary glaucoma, meaning there are no other causes, there are no underlying general medical conditions. It's just that glaucoma occurred. When I talk about congenital glaucoma, as the term implies, congenital, meaning the problem is already present at birth. Okay, it is already present at birth. There is abnormal development of the filtration angle at the cornea and the iris. Again, the problem there that you need to highlight is the abnormal development of the angle between your cornea and your iris. Okay, it's rare. Congenital glaucoma is rare. On the other hand, when I say secondary glaucoma, just like your other disorders, when I say secondary, meaning there are underlying causes on this disorder. And on this case, the underlying causes class could be your uveitis, which is the inflammation of your uvea. It could also be your cataract, which has been unresolved by surgery, and then the presence of your tumors or abnormal growth, such as your ocular melanoma. So recall that your ocular melanoma could also be present in your uvea. So for that reason, class, it could also lead to your glaucoma. Okay? Now, how come that the intraocular pressure would be increased? If you would look at plus your intraocular pressure, recall in our discussion in assessment that your intraocular pressure is taken care of by your aqueous humor. Okay, your aqueous humor. And your aqueous humor is traveling through the anterior and then the posterior chamber. Okay, now, if there is a problem on the drainage of your aqueous humor, the tendency of your aqueous humor is to build up. The tendency of your aqueous humor is to build up. And with the building up of your aqueous humor, there will be an increase in your intraocular pressure. Okay? There are two main types in your handouts that would be categorized under your primary glaucoma. So there are two main types there. You have your open angle and then your closed angle glaucoma. You need to note, class, that when I say open angle glaucoma, it is considered to be chronic, it is considered to be simple, it is considered to be wide angle. Which means when you hear the word chronic glaucoma, simple glaucoma, wide angle glaucoma, that would be referring to your open angle glaucoma. Okay, that would refer to your open angle glaucoma. Okay, if you would look at this, class, this is the differentiation between the two glaucomas. As the term implies, open angle glaucoma, it's open angle, meaning, class, there is still a possibility for the aqueous humor to pass through. However, this drainage here or this area here is narrowed in your open angle glaucoma. In your closed angle glaucoma, class, what actually happened is that the angle is already closed. Okay, the angle is already closed, meaning your aqueous humor has no way out. Okay, now, let's first expound on your open angle glaucoma. So when I say open angle glaucoma, the obstruction will be on the trabecular meshwork. Okay, the usual obstruction will be on your trabecular meshwork. And when I talk about your trabecular meshwork, you have there your canal of Schlem, okay, the aqueous veins, and this is usually related to degenerative changes. So when I say degenerative changes, that would be usually related to the aging process. That's why your open angle glaucoma would be more common among old people. Okay, now, allow me to jump first on the assessment findings of your open angle glaucoma. Okay, open angle glaucoma, class, would usually involve bilateral eye. However, an eye would have more severe manifestations compared to the other eye. Assessment. Assessment, it would be insidious. So when I say class insidious, the onset of which is slow. Okay, earlier I related it to aging process. So it's just slow class. So generally the patient will not be feeling any discomfort because it's a chronic process. Okay, it took time. So the patient will not say, oh, there's a sudden change in my vision. No, they would think that's just blurring of vision. And then class, we refer to the abnormality in your open angle or in your glaucoma in general. We refer to the abnormality as your tunnel vision. It is tunnel vision because what you can see is as if you are looking through a tunnel because there is peripheral vision loss. The tendency of your patient is to ignore the objects on the sides. Okay, the tendency of your patient is to ignore the objects on the sides. Peripheral vision loss. Next, you will have mild aching in the eyes upon waking up. Okay, why class? When you were asleep, the flow of your aqueous humor is minimal. Okay, when you were asleep, the flow of aqueous humor is minimal. Hence, the tendency is there will be a dull eye pain, which would be present, especially when you are waking up. Next, your patient would also have the tendency to change their eyeglasses frequently. Okay, it's as if class nga, oops, it was just 6 months ago when I had my glasses. Why is it already changing right now? Because class, they do not know that their glaucoma is already progressing. They will have difficulty in adjusting to darkness. They will be unable to detect color changes accurately, class that is related to the compression already of your optic nerve. They have the tendency to see rainbows or halos resembling streetlights through a steamy windshield. And then their tendency again is to have reduced visual acuity at night. Okay? So these are the problems encountered in open angle glaucoma. If you will try to memorize all of those signs and symptoms class, you will have hard time. Okay, because that will be later on almost the same with your acute angle glaucoma or your acute glaucoma. But one thing that you need to remember for this one is that it is insidious because again, this is usually caused by degenerative changes. And then again, it is not very severe since there is still an opportunity for your aqueous humor to go out. There is still an opportunity for your aqueous humor to be drained out. Okay? Now, let's go to your close angle glaucoma. Class, when I say close angle glaucoma, let's have the terms here on the right. Class, these are the terms which are synonymous to your close angle glaucoma. They would say acute glaucoma. They would say pupillary block glaucoma. They would say narrow angle glaucoma. Again, when I say close angle, it could be acute, it could be pupillary, it could be narrow angle glaucoma. With that being said, class, this is actually the ophthalmic emergency between the two glaucomas. Okay, so between your acute and then between your chronic glaucoma, of course, it's the acute glaucoma. The problem here is that there is close angle. So when I say class close angle, if you would look at the normal eye, okay, this is your lens, this is your anterior chamber here, you can see class that the aqueous humor can freely flow through the chamber. It could freely flow going towards the trabecular meshwork, it's here. It could freely flow going towards your canal of Schlem, okay, which would facilitate the drainage of your aqueous humor. However, class, what happens in your narrow angle glaucoma or your close angle glaucoma? It's close. It's close. Okay, that's why class, it's also referred to as your pupillary block. This is already your pupils class. Okay, that is your iris, I mean. Okay, that's why class, it's already referred to as your iris pupil block or sometimes referred to as your pupillary block. Remember that your pupil is your opening to your iris. Okay, that's the block class, meaning the aqueous humor could not go out. So what happens? The fluid stays here in this chamber and then there will be a continuous increase of your intraocular pressure. If not addressed, your patient would have blindness, okay, within matter of hours, okay, and the blindness tend to be irreversible. Now, the key words there that you need to highlight, narrowing or closing. There is narrowing or closing because of the root of the iris, as shown on this diagram. Okay, there is narrowing or closing because of the root of the iris. Now, usually, if you would look at class D assessment, the pain would be unilateral. Unilateral inflammation and pain. Your patient would complain of pressure over the eye. Your patient would say there is moderate pupillary dilation. It would be non-reactive class to light. the cornea would be cloudy, there will be blurring and reduced visual acuity, photophobia, and then nausea and vomiting. Okay? What is unique if you would compare open and close angle glaucoma is that in close angle glaucoma, it is more of unilateral. Earlier in open angle, we are saying that it could be bilateral with one eye more severe. Okay, for this one class, it would be unilateral. What's also unique, class, is that the pupillary dilation is already affected. Okay, the dilation of your pupils, it's moderately dilated, and then it has a tendency to be non-reactive to light. Why non-reactive to light? Your iris, class, is not already moving, and then because of increased intraocular pressure, your pupils will also not be able to move. Or it could be also that it is your pupils who block, okay, or which block the flow of your aqueous humor. Okay? Take note of that. Now, the photophobia, you've heard about that, but nausea and vomiting is also unique to your close angle glaucoma. Okay? The sudden increase of your intraocular pressure would trigger your patient to have your nausea and vomiting. So with that being said, I hope that you will be able to differentiate already between acute angle and then close angle glaucoma. And then be able to familiarize yourselves, class, with the different terms that is being used to describe these types of glaucoma. Now, so class, this is actually an example of an acute angle closure glaucoma. Based on this image, this would actually show a right eye with an IOP of 42. So that's double the normal. And then the IOP is 42 at the right eye. And then class, if you would note the left eye, you can notice that there is a mid-sized pupil on the left that is non-reactive to light. And there is presence of conjunctivitis. Plus, the presence there of your conjunctivitis is also related to the increase in intraocular pressure. Okay, the blood vessels, class, are unable to address the blood flow properly. That's why your patients are having, okay, your patient is having conjunctivitis. Okay, next. So class, this is how they would view. Okay, this is the tunnel vision that we are talking about earlier. Now, so siling natin, there is tunnel vision. Now, this tunnel vision, class, is related to the peripheral visual loss of your patient. Okay, if the healthy eyes would be able to see this, this is how a patient with glaucoma would be able to see it. Now, what is our management for this patient? Okay, plus the overall goal of this management is to reduce the IOP and to keep it at safe levels. That's the overall goal. Okay, beta blocker, recalling pharmacology, you have your olols, okay, your beta blocker. Particularly, class, in your eyes, we use your timolol. Okay, your timolol, class, other than being a beta blocker, which is expected to reduce the pressure because it's an olol, it also, class, decreases your aqueous humor production. Diuretics. Class, recall, there are several types of diuretics. You have your loop, you have your thiazide, you have your osmotic, your potassium sparing. The fifth one that we rarely talk about is your carbonic anhydrase inhibitors. Class, your acetazolamide is a carbonic anhydrase inhibitor. Okay, it's a diuretic. Its purpose also is to decrease aqueous humor production, and then add to that, since it is a diuretic, it facilitates also, class, the excretion of your aqueous humor. Now, you have myotics. When I say myotics, if we say mydriatics would dilate the pupils. When I say myotics, its aim is to constrict the pupil. Remember, thus, your pupil acts as a doorway to your eyes. So when I say doorway, if it is dilated, the tendency is that it does not allow it does not allow aqueous humor to come in and out. Okay? So we want it to be constricted this time because we want aqueous humor to come in and out. So we want the pupil to be smaller. So the mechanism of action here is that it would cause pupillary constriction to open the trabecular meshwork, and it would facilitate the flow of your aqueous humor. Examples of which are your pilocarpine and then your carbachol. Okay, pilocarpine and carbachol. Now, surgery. So class, there are different kinds of surgery that could be done for this patient. Okay, so one is your trabecular meshwork. Let's proceed, class, again to the surgery. So trabecular meshwork. Class, what happens here? Remember, this is your trabecular meshwork here. So class, your trabecular meshwork is the one responsible for draining most of the aqueous humor. Okay, class, trabecular meshwork here, by the way, is not a surgery. Trabecular meshwork is part of your anatomy and physiology. So when I say trabecular meshwork, it is the one responsible for draining your aqueous humor. So that is one of our problem when our patient would have glaucoma. There is narrowing of your trabecular meshwork. Okay? Now, One of the procedure that we can do is your laser trabeculoplasty. As the term implies, trabeculoplasty, plasty, meaning we attempt to repair the trabecular meshwork. Okay, so class, it is used to lower the IOP. Yeah, all of these procedures are intended to lower the IOP. Okay, just remember class, it uses laser. Okay, it uses laser in congruence to your eye medications. And the purpose of that is to open up the trabecular meshwork in such a way that the aqueous humor outflow will be good. Take note, this may take up to 2 to 12 weeks before the patient will be able to feel the benefits of your laser trabeculoplasty. Next, you have your laser iridotomy. Plus, in your laser iridotomy, instead of relying class on the drainage there on the part of your iris, remember you have your iris root here, which earlier in your close angle glaucoma is the one which is close. Okay, so class, what happens? In your laser iridotomy class, a hole is being made, an iris hole is being made. Okay, and that would act as a temporary or that would act as a passageway class of your aqueous humor. Okay, again, 1 to 6 weeks for the patient to feel the benefit. And then you have your filtering procedures, trabeculectomy. Okay, class trabeculectomy. So what is being done in trabeculectomy? If you would look at this diagram, okay, there is a drainage pathway which is being created. If this is blocked, so what is being done? Okay, a pathway is being created again for the purpose that the fluid will be drained. So it would involve creation of a fistula that would connect the anterior chamber to the subconjunctival space. And that is where your aqueous humor would be draining. Okay, that is where your aqueous humor would be draining. Now, post-op care. After your patient have had this surgery for your glaucoma, what will you do? Okay, eye is expected to be covered with metal, okay, a patch or a metal for plastic shield protection. You instruct the patient, if the eye is operated on the right, your patient is not supposed to lie on the right because that would put pressure on the operative side. And then, of course, do not rub or apply pressure over the closed eye. That's why, class, these patients would have your eye patch. If they're asleep, it would be recommended for them to have your eye shield. Why eye shield, class? Because if it's eye patch, there is still a tendency for you to scratch through. Scratch through, I mean the eye patch. Whereas if it is an eye shield, by the time that you attempt to scratch your eye, you will be made aware that there's something that blocked your eye. And then you will wake up and then you will recall that there's a purpose why your eye is blocked that way using the eye shield. Okay? Now, what are the possible nursing diagnoses for these patients? Of course, you'll have your sensory perceptual alterations. Visual, because remember, there is inability to process your visual stimuli. Cranial nerve number 2 is already compressed. Second, non-compliance. Okay? Why non-compliance? The tendency, class, of a patient with glaucoma will say, oops, my drugs or my meds are not even effective. Why take this medication? Okay, so you need to educate them. That would also take time before the aqueous humor outflow would be improved by the medications. Sometimes more than a week. Anxiety and fear, especially if you're dealing with acute angle glaucoma. Okay, anxiety and fear is more common in your acute angle or your close angle glaucoma. Potential for injury. Remember, you have your tunnel vision. Plus, the tendency of your patient pala with your glaucoma is that they tend to bump to other people. They could not see vehicles approaching, class, and they do not know that it's their fault. Okay? The tendency, class, is they could not see the vehicles approaching because of their peripheral vision problem. They could not see that people are coming along their way because of their peripheral vision problem. And then at times, they will be the one who will get mad, okay, when they are bumped too. But they fail to recognize that it's actually their fault because of their glaucoma. Okay, then you have your potential for injury, social isolation, and then self-care deficits. Why are you having social isolation? Their tendency is that they will not be going around because of their tunnel vision. Okay, while self-care deficit, if there will be blindness, class, they will be unable to care for themselves. Again, your next topic is eye trauma. So class, when I talk about eye trauma, we're referring to injuries. Okay, we're referring to your accidents. Now, there are several types of your ocular trauma. One, chemical burn. When I talk about chemical burn, class, think of your household. Okay, think of your household. It could be a strong acid, it could be a strong base which is used in your household. It could be the detergent, it could be the muriatic acid. So what will be your immediate intervention? So class, ensure that there is immediate irrigation with tap water or normal saline. And when I talk about class immediate irrigation, it should be running water that you will be using. Next, foreign body. If there is presence of foreign body or accidental dislodgement of foreign body to the eye, please do not remove the object or do not attempt to remove the foreign object. Do not also apply class pressure or patch because you are aggravating the problem of your patient. You're just pushing it. So what will you do is to protect using a metal shield or a stiff paper cup. Okay? How can a stiff paper cup work? Okay? This is how it is done, class. Okay? So metal shield, if it is not something which is pointed or if it's not something which is long, but if it is long, class, you need to use your cup. Usually, class, we recommend the use of your paper cup. Okay? And then tape like that. What's the purpose of this class? To prevent also the dislodgement of whatever foreign object, and this is that, and also to protect the eye of your patient. But never ever attempt to remove it. Okay, it would increase the injury of your patient. Then, you have your blunt injury. So class, for your blunt injury, of course, blunt object. Okay, assessment, look at that. There will be edema, there will be subconjunctival hemorrhage, corneal edema, hyphema, I mean, periorbital ecchymosis or black eye. Okay, black eye, your management is ice pack. And then class, you need to have your eye examination to rule out eye injuries. And then antibiotics here is only given not because of infection, but because of the risk for infection. Hence, the purpose is only prophylactic. Now, about your hyphema, class, when I say hyphema, that is the deposit here of your blood, okay, on the outer layer of your eyes. Class, usually, your hyphema could self-resolve. It could self-resolve. In other words, class, it's just gone on its own. Okay, it can just be removed on its own. It will be reabsorbed back to our system. However, if it's chronic already, that's the time that you need to see your doctor already. Okay, for this case, class, an eye examination is recommended. Hence, that should also be done by your doctor. Next, you have your penetrating injury. Your handouts would say that when I talk about penetrating injury, that could be your glass, high-speed metal, that could be your wood particles, your pellets, your bullets. So these are the most common cause of your penetrating injuries. Plus, for your penetrating injuries, hospitalization, ophthalmic emergency. Apply eye shield on the way. Then use your topical steroids. The purpose of your steroids is to decrease your inflammation. Your aminocaproic acid, class, is intended to halt the bleeding of your patient. It is intended to halt the bleeding of your patient. Okay, it's an anti-fibrinolytic agent. When I say class fibrinolytic, fibrinolysis, meaning it stops fibrin. It stops clotting. But this time it says anti-fibrinolysis, meaning class it facilitates your clotting. Aminocaproic acid. Then aspirin, of course, is contraindicated. Okay, ASA, acetylsalicylic acid aspirin, is contraindicated because of the risk for bleeding. Next, what are the options if you would have a penetrating injury? So you have your vitrectomy. Okay, I think I've used vitrectomy on previous recorded lectures. So class, in vitrectomy, there will be an exploration of your vitreous, humor, okay, if there are further damage. Or, if it serves you well, enucleation. Okay, the removal of your eye. Okay, the removal of your eye. Plus, after the removal of an eye, sometimes a prosthesis there is being placed just to ensure, class, that the face will not be deformed later on or that there will be no deformity of your orbit. Okay, in some cases, class, that part of the eye is just patch. Next, you have your chemical injury. So, class, chemical injury, it could be an alkali, such as your lye or your ammonia. It could be an acid. Okay, you have your muriatic acid. Okay, so class, if you would look at the alkaline or the alkali substances there, class, it is actually among the most common, what you call this? It usually leads to most severe injury that would lead to an immediate rise of your IOP or your intraocular pressure. And then, class, you have their substances. They mentioned about mace and then your tear gas. Okay, class, your mace is about your pepper spray. Okay, they can cause chemical burns. They contain chemicals that would cause chemical burn to your eye. Okay, so this may also include your other chemically active organics. So again, for your chemical injury, chemical burns, tap water. Okay, it should be running tap water that you should be using. Okay, then before that, okay, I would like to talk about the possible signs and symptoms that could occur in your chemical injury. So they may appear as superficial punctate keratopathy. So class, when I say superficial punctate keratopathy, that is usually related to the death of small groups of cells, okay, especially in the cornea. So the tendency is that the eye become red, watery, and sensitive to light and vision. Okay, sensitive to light and vision. Your superficial punctate keratopathy. Then you have your subconjunctival hemorrhage. Class, your subconjunctival hemorrhage is a red spot on your eye which is caused by a broken blood vessel. So this is caused by a broken blood vessel. And then you have the complete marbleizing of the cornea. So class, complete marbleizing, as in class marble, the marble stones that we are talking about. So your cornea would appear like that in severe situations. Okay? That would indicate actually poor prognosis already. This is actually class the staging for chemical burns when I talk about eye problems. Okay? Going from stage I mean to E, you would notice that stage E, the prognosis is poor. The prognosis is very poor in stage E. Why, class, there is presence of your marbleized cornea with more than two-thirds of the limbus being ischemic. Okay, limbus is part of your eye. Ischemia is, of course, decrease of blood flow and oxygen. So, class, very poor prognosis on this one. No need for you to memorize, but I just would like to tell you that if it's stage E, it's already poor prognosis. That's the message. Okay, so again, going back to treatment, so there will be tap water irrigation, application of your local anesthetic. So class, your local anesthetic uh, is applied to to relieve the pain of your patient. Then you use your lead speculum. Plus, the purpose of your lead speculum, what we refer to here as your lead is your eyelid, no? Eyelid speculum. It's here, shown on the right. Okay? Speculum, something to open it up. So, class, the purpose of your lead speculum is to stop the blepharospasm of your patient. Okay, again, when I talk about blepharospasm, it's blinking that we cannot control. Okay, and then class, you have your particulate matter removal. Now, it must be removed from the fornices using your moistened cotton tip applicators and minimal pressure on the globe. Plus, when I say globe, that's the globe of your eyes. Okay, so class, if you can notice, we are using moistened cotton tip applicators. What is the hope of that? Is that the moist cotton tip applicator would be able to attract, or is that the foreign body, I mean class, will be able to attach itself to the moist cotton applicator. Okay, we are rarely using instruments to the eye. On our part as nurses, if you are unsure as to how to do it, class, better for you to bring the patient to the ER or bring the patient to an ophthalmologist and have them seen by an ophthalmologist. And then you have your eye patch. Okay? Plus, you may use your antibiotics because in your chemical injury, it would also usually also involve infection. Because of the irritation, class, there is a possibility that there is impairment on the protection of your eye, leading towards infection. Then you have your thermal injury. Thermal, as the term implies, hot. Okay, hot object. Maybe your curling iron, your tobacco, your ash. Okay, especially if you have volcanic eruptions. Then you have your photochemical injury. Plus, for your photochemical injury that is related to your ultraviolet radiation or infrared exposure. It could be exposure to the reflections of your snow, sun gazing, viewing of an eclipse without your protection or your filters. So what's the effect? The corneal epithelial defect would occur. There will be corneal opacity. There will be conjunctival chemosis. There could be class injection and burns of the eyelids and periocular region. Okay, burns. So class, what do we do in your thermal injury? Your patient, class, would have antibiotics and pressure patch for 24 hours. Okay, class, antibiotics here is not for 24 hours, so it should be at least for 5 days. Then surgery, you have your oculoplastic and then your corneal surgery. Oculoplastic, class, meaning there could be repair of the eye structure. Corneal surgery, class, it could be the replacement of your cornea already. Because remember, the uppermost layer of our eye would involve your cornea. Okay, that clear, transparent layer of your eye. So sometimes, class, it needs to be replaced because of thermal injury, or else your patient will not be able to see clearly. Then you have your foreign body. Okay, class, foreign body, it could go as far as your eyelash, dust, fingernails, dirt, airborne particles. Okay, come in contact with your conjunctiva and abrade the surface. Okay, now you need to highlight there the word irritate and abrade. Okay, it may irritate your surface, the surface of your eye. It may abrade. When I say abrade, class, abrasions, okay, it's just like your minimal lacerations. For that reason, class, when there is a foreign object or foreign body in your eye, you are not supposed to scratch it. Okay, you are not supposed to scratch it because you're increasing the risk for abrasion. So what happens? Assessment. There is feeling of something being in the eye, blurry vision, pain, tearing, and photophobia. Okay, this may be present in your foreign body. So what do we do? Okay, if there is a suspected corneal abrasion class, first you need to do a diagnostic test, or the ophthalmologist, would need to do a diagnostic test. There you will have your fluorescein, okay, your fluorescein. So class, cornea, remember cornea is transparent. So we need to have a fluorescein. Your fluorescein is actually a dye. If you can recall our discussion in assessment, it is a dye that would help us visualize your cornea. Okay, and then in foreign body class, foreign body obstruction, or foreign body, on your eye, you would need to also to have your NSS irrigation, and then you need to have your eye patch, and then ophthalmologist consult. Then the purpose of your ophthalmologist consult is to assess plus the damage or the extent of damage to the eye of your patient. Okay, as nurses generally, we are not managing ophthalmic problems. Okay, it's not like doing first aid to wound that it would be easy. Okay, you need experience class for you to adequately manage the eyes of your patient. So if you do not know what to do, at least you know that irrigation could be a step, applying of your splint could be a step, applying of your protection could be a step, and then you bring your patient to the emergency room. If not the emergency room, bring to the ophthalmologist for consult. Okay, that will be the end of your discussion on eye disorders.